So Declan, here we are in beautiful Adelaide for the 2024 USANZ meeting.
It's nice to be here down by the banks of the beautiful River Torrens here in city centre Adelaide, Australia's fifth largest city, I think.
Oh, you're testing me. Yeah.
With 1.3, 1.4 million people right down on the south coast of Australia for the annual scientific meeting of USANZ, the Urologic Society of Australia and New Zealand.
It's such a stunning location because the convention centre overlooks this beautiful river and there are people out there running and on the water.
And this beautiful stadium right behind us here,
the Adelaide Oval.
Home of many famous international cricket matches. And what's her face is playing a concert there tonight or tomorrow night?
Oh, yeah.
Pink. Yeah. So
Pink is playing.
Yes, Pink is playing, but the big gig for us is...
and it's the Adelaide Fringe Festival, so there's a lot going on here.
Yeah.
But of course the highlight for us is the meeting.
Exactly. So we've brought you Congress highlights before of the USANZ meeting. It's a great meeting. I often describe it as a medium-sized international urology meeting. There are about 1,000-odd delegates, 14 or 15 international faculty, and very importantly, we combine it with the annual scientific meeting of our nurses of Australia, New Zealand, ANZAUS as well. So it's got a really good collegiate feel across Australia, New Zealand. 1,000-odd people, and it's going to be good.
And a good mix of science and social events. It's going to be a fun few days.
It sure is. And over the course of the podcast, we of course will bring you a flavour of the meeting, a flavour of Adelaide, and we'll catch up with some of the faculty, some of the local faculty and some of the international faculty for a few highlights of USANZ 2024.
And Declan, you convened the meeting in Melbourne last year. Are you going to be able to finally relax?
Yeah, it is a bit stressful being the convener of these meetings, so big shout out to Michael Choong and Dixon Woon, who are the urologists leading the scientific committee. Hopefully we might track them down for a chat.
I think we will. We better do that.
And we will catch up with them. But yeah, it's much nicer to be on the far side of it, I must say. I'm enjoying this meeting more than last year, which was a bit hectic all the time. Hectic but enjoyable.
Let's go and get some interviews.
Let's do that.
Okay, so it's the official day one of USANZ 2024, and I've got a very special international guest, Dr. Robert Nam, all the way from Sunnybrook in Canada, and of course joined by superstar Declan Murphy of GU Cast, the one and only, and these two went up head to head today in a debate.
The great
That's right, the great surgeon.
He really had a go at me. It was character assassination.
He did a great job with that. So the topic of the debate was, is open surgery dead? Declan fighting for the affirmative and Rob for the negative. Rob, I think you've done some debating in the past because you almost scored a win just with the definition alone.
Well, no, yes, by the definition alone, but by far I'm not a pro at this, and I think we all came to the same conclusion.
We did. We no real fisty blows.
Right. Yes.
Yeah, we were all very disappointed. So Declan, why is open surgery dead?
Yeah, we were asked to debate it. It was a good topic, wasn't it? And I was supposed to argue, yes, open surgery is dead. But as I think about the topic and you think about your own practice, clearly the first conclusion was open surgery in 2024 in urology is not dead and never will be, actually. But I think we all agreed that it's in steep decline. And particularly index procedures like radical prostatectomy, open radical, and we showed some data from Australia showing robotic surgery is now 85-90% of procedures here, and we don't want to argue is that the right thing or the wrong, but that's the way it is. So I think while I also showed examples from Peter Mac Cancer Centre, big open surgery we still do there. A theme we came back on, Rob, was that what about trainees? What about the next generation of trainees? If an index procedure like open radical prostatectomy, where we all learned how to safely enter into the pelvis and control bleeding and join stuff back together, is no longer commonly performed, how are the next generation of trainees going to do that? So. And so that's I think we agreed on a similar theme.
Absolutely,
and Rob showed some amazing examples of stuff that clearly is best done with open surgery, always will be, these certain challenging tumors. But
I would say your data is very concerning about training open surgeons when you need it the most. And the question is, where and how are they going to receive it? And I don't know the answer to that. And I think in the future we got to consider those things in advanced residency training or registrar training, if you will, or fellowships. Yeah, absolutely.
I remember when you were here at the last USANZ that I was the scientific convener, 2017 or 2018, and I remember there was a similar talk, and you were talking about maybe we should have like fellowships in open surgery.
Yes,
type of things that because you were already recognizing that maybe not everyone needs to do the surgery you do or I've done in the past, but we do need people to do that, to learn open surgical skills, how to access places, how to use these basic instruments to
Yes, absolutely.
control vessels
Yeah.
and so on.
Yeah.
Because while there's a generation of surgeons who are very, very good at doing that with MIS tools,
Right.
you know, if suddenly you have to open a cavity, big patient, you
Yes,
down into that,
yeah,
you know, deep
yeah.
down there where there's bleeding, and you don't have the dexterity or the familiarity with the tool,
Right,
so
right.
maybe dedicated training.
I think so, and
probably in cancer centers.
Yeah, you know, you actually gave me some more food for thought that maybe in our training program for fellowships, we should have a separate arm for open complex surgical training, separate from the robotic training.
Absolutely, and it's an interesting conundrum because it's not just about getting the skills, but you need to keep up those skills too, which is really challenging in an environment like what we have now.
Yeah.
And it's particularly challenging, Declan, I think, in Australia because a lot of our public hospitals still don't have access to the robot, but a lot of our fellowship-trained surgeons are coming back now robotically trained and not really keeping up their open skills. So who's going to impart these skills to our
Open
trainees?
invitation to Sunnybrook. Please send us your trainees.
Where there are maximally invasive surgeons.
Australians love going to your centre.
We
Many of them have been there.
yeah,
so.
we love Australian trainees coming up. They are just first class, terrifically trained already, and they just melt into our system seamlessly. So it's just perfect.
And Rob, you've been a mentor, in fact, to a lot of our surgeons here.
Not a lot, but some.
A few memorable ones.
Yes,
Absolutely.
yeah.
It must be nice for you to come back to Australia and see them all thrive.
I love coming back here. You know, I tell you, we used to be a Disney family, and their motto is "Welcome home." When I come to Australia, I feel like I'm at home.
You do,
It's just wonderful here. It's just I said this in the past. I was offered a job in Sydney. I won't go into details. Many years back when I started training. Sometimes I regret saying no.
Oh, wow.
Sliding door moments.
Yeah.
Speaking an Australian accent.
And while we've got you, Rob, you know, you gave a great talk at one of our workshops yesterday about the MVP trial, and that's looking at MRI versus PSA in a screening
That's right.
role. And, you know, we recently had a podcast about the Reimagine trial with Caroline Moore, so it was really interesting to hear your data.
Yeah.
Can you just quickly summarize it for us?
Well, you know, I dared to ask the question. You know, we've been using PSA for so many years or decades. How about replacing it with something better, maybe imaging? So I did a randomized trial comparing PSA versus MRI in a screening setting, and we showed that MR can better recommend who needs a biopsy, more identify aggressive cancers. Not only that, save unnecessary biopsies. So perhaps the math will work out in the end, that it is worth doing MRs rather than spending money on invasive, unnecessary biopsies and unnecessary treatment.
Yeah,
Time will tell.
absolutely.
Yeah.
And then the feasibility of doing these MRIs in a screening sort of population.
Yes, that's the key.
But it's interesting because I remember at the EROS, the European Robot meeting last year, September, they were showing off this dinky like office MR machine specifically for that sort of thing. You can plug it into a normal electricity point and it'll do like basic 0.4 Tesla things.
Yeah,
So it's kind of a yes/no, like Caroline's trial, a yes/no thing. It's not like the super detailed multi-parametric MR, but maybe you don't need that in the screening population. It's just a decision of I'll go on and have a multi-parametric MR. But for loads of people, it's all you need.
I mean,
so if it's a small, easy thing in the office.
Absolutely, if the technology catches up, who knows?
And the other great talk you haven't given it yet, but we've got a little snippet of it, is the impact of COVID on prostate cancer screening and diagnosis.
Well, you know, in Ontario, we had several lockdowns. We call it state of emergencies. And we looked at over 800,000 men, see what happened to their PSAs. And after the pandemic, they didn't get them, obviously, but then they came back with extreme PSAs, greater than 50, greater than 100, and a higher rate of more advanced treatment.
Wow.
And it's funny, I was going to say this at the end of the talk. We sent this to JAMA, and JAMA rejected it. But you know why? In their letter of rejection, they say, we want studies that promote vaccinations. Do you believe they politicized?
Oh my
Which
goodness.
was nothing to do with the study.
They politicized the scientific process. I was shocked.
Come on, Jan, get your act together.
Oh my goodness. That is shocking.
We've all been kind of waiting for this, haven't we?
Yeah.
We've all known
Right,
that it's
right.
like we had extreme lockdowns
absolutely,
as well.
yeah.
What is the impact? And so we're beginning to now see it. So this data is really important because we haven't seen the data from Australia. Because we did measure that during those periods, the number of men having a PSA test went down by 25%.
Referrals went down.
That's right.
But now they're definitely trickling back
They're
in.
trickling
and you
back.
measured it, and we haven't
And
fully
it's
measured
awful.
it yet.
And we all see it in our practice, which is why I started to ask the question.
Yeah.
And the PSAs of 50 or 100 is going to lead to more advanced treatment.
Yeah, absolutely. Now, Rob, when you were planning a trip to Australia, you had to make a decision between bringing your wife and bringing your golf clubs.
I hope my wife's not listening or watching.
Was that a tough decision to make, and do you have any regrets?
Absolutely not. It was not. It was like a slam dunk. You know, it's like when your spouse asks you, "Do I look fat?" No.
See, now you've said it on camera, and it's immortalised.
You didn't actually say which did he bring.
Right.
There's absolutely no regrets, but
absolutely.
You'll have to guess, folks. I'm not sure, did he bring the golf clubs or bring his wife?
That's true. Which one did you bring?
Well, it was no regrets either way.
There's no regrets.
No regrets. Leave it at that.
So I met Mrs. Nami yesterday, which was very nice to meet her as well. Yes, that was great.
Well, we really hope you have a wonderful
thanks
time
so much.
here with your wife and enjoy the travel around.
This was a lot of fun. Thank you.
No problem. Take care.
Thanks.
So Declan, you know, it's day 2 of the meeting, and I think one of the true highlights has been the talks by Paul Anderson.
Yeah, it's been great to have you here, Paul.
Yes, I'm loving it. This is my first USANZ. I think it might be the best conference I've ever been to. All the doctors seem so content in their work. And, you know, and in the NHS, people are just so worn down, and we're just in the middle of another junior doctor strike. Yeah. And I can see why people come out here to work.
And they do certainly come out, and in the old days they'd come out and do a fellowship, a bit like I did, coming from London, and go back. But now a lot of people are going one-way traffic from the UK. The morale seems to be very low in the NHS.
Well, Professor Declan and I were trainees in England together.
Oh, is that right?
And he's been going on forever about how nice it is out here, and I can finally see what he's going on about.
You watch out, Paul. You might actually move here if it weren't for the
old.
important work that you do.
I'm too old.
So look, it's been great to have you. You've done some wonderful talks here. Yesterday you did a great talk about your work going to poorer countries to do some of the work. You enjoy your reconstructive surgery.
I mean, I love going out to the low middle income countries. And last year I had a load of COVID leave I had to use up in 2023. So I did 5 charity trips, which was a bit hard to fit in around my other work, but it's incredibly rewarding. You go out there, you teach surgery, you operate yourself, you have interesting conversations, you get to see the culture. It is selfish and selfless. I get more out of it, than I give. I come back feeling, reinvigorated with my interest in reconstructive surgery, and I've helped all these people, and we stay in touch when I get back. So it's a bit like a drug, and I'm back to Malawi in April, and I think Tanzania in November. I'm looking at the Gambia as well.
It's interesting, isn't it? Because you showed some pictures of the conditions there, and we complain about suctions not being good enough, and operating lights not being bright enough, and how do you cope with that? And do you have to keep going back quite often, or if you
the first visit I ever did, they must have thought I was a complete prima donna when I was saying, well, no, hold on, I want the 8mm needle, or the 11, or the 13, or maybe the 16,
or a knife that actually cuts.
That's your suture. That's it. That's your suture.
Yeah.
So and after that, you learn to adapt much more, and it makes you a better surgeon. Because you can work in adverse conditions, and then when you come back to the NHS with amazing light and suction and the whole selection of needles, you're faster. As a simple parameter would be, if you went and did this stuff in a low middle income country, when you come back to your high income country, you'll be operating faster because you just find it easier.
And they're a very grateful group of patients.
They're very grateful. I mean, if you've had a catheter for 6 years and you can fix them, then yes, they are absolutely, delighted. Absolutely delighted. And you feel like you want to keep going back to help more of them. But the key thing, you've got to train the surgeons. That's the key thing. And longitudinal engagement. You can't just go once. You've got to keep going back to see their improvement.
And do you
get them
see their progress when you go back?
Totally. Yeah, totally. I think in one of my slides, I said how it started, how it's going. So you might end up doing all the operating in the first visit. By visit 4, you're assisting the majority of the time. Do the odd really complicated one, but it's really gratifying to see their skills come along. And as I said, it's not like training registrars. I'm training someone that can do a paediatric heminephroureterectomy or a Minds 2 pouch. They've got the skills, they know how to operate. They just don't know that particular operation. So it's different.
Yeah. And today's presentation, Paul, it was incredible. Like, we were speechless by the end of it. Those photos you showed of, the perineal injuries. I was quite emotional
in that talk.
Yeah.
A bit choked, when I think of it. Because you do get this longitudinal relationship with the soldiers, the particular ones. Yeah, it's a good talk. I've given it in many countries. People see it in Ireland, then invite me to Australia to give the same talk. Sometimes I think it's a bit sad that my best work was done a decade ago. I didn't even realise. Nothing really has come close to it since. I hope we don't see any of those injuries again from either Ukraine or Israel or what have you. Just hope it doesn't really get to that again.
So there was a peak period when it was these landmines, as you say.
So it was the
IEDs.
improvised explosive devices, the IEDs, but it was combined with the fact that for the first 18 months of the IEDs, the MOD hadn't brought out the amazing ballistic protection, which they created, and I showed in that slide, which is sort of like triple thick silk rugby shorts, cycling shorts, to stop the ingress of shrapnel, and then a Kevlar box. That was level 2. Level 3 is like the stuff in the hurt locker, the bomb disposal experts use. And that made a huge difference. So until we had the pelvic protection on the soldiers, yes, we were seeing that awful signature injury with legs lost, anorectum blown apart, genitalia gone, pelvic fracture blown apart. Yeah.
I mean, some of the reconstruction that you did was incredible, and it's quite creative work, isn't it?
Yeah.
And a lot of these techniques, I'm sure, are established techniques, but did you find yourself having to think up new ways of solving a problem?
Well, actually, my plastic surgery friend, Dimitris Evriviades, shout out to Dimitris, he went back to the old textbooks because you couldn't be doing, microsurgical free flap type stuff. He was looking at textbooks from the First World War and saying, well, let's just march this flap across the body to do things because the vasculature was compromised. And so he went back to the old techniques in order to solve these problems.
Wow, that's incredible, isn't it?
It is amazing, and I think one of the themes of this was managing expectations, and it's
Absolutely.
not going to be normal, but Paul was showing pictures of these completely devastated groins after huge explosions, and so if they survive it at all, and you're only getting in there months and months later, so they've, I suppose, got used a bit to, like, there's a suprapubic catheter, the penis might be missing, lots of stuff is missing. So in managing, did you learn as you went along to say, what am I going to say to this poor chap, that what can I achieve for you? And maybe it's I think I can get rid of the suprapubic.
Yes.
And, like, I suppose under promise.
Absolutely. It is all about managing expectations, but life is about managing expectations so you don't end up with disappointment. So yes, very early on you want to give them realistic expectations of what you cannot achieve. Definitely.
And when these men have lost their limbs, it's so important, even the little things you can do to restore a sense of normalcy when it comes to their genitourinary organs is really important.
Definitely. And that it's a shame, but when you lose both your limbs, the physical effort is something like 300% compared to normal for us walking. And they often gain weight, and a lot of the ones that started off on the prosthetics will now have migrated to, a wheelchair 10 years on, because they just wear the joints out. It's just difficult for them. It's hard.
Great stuff. Well, look, great to have you.
What have you got planned? You've got a few friends in Australia you're going to visit?
I am off to Perth to see Hugh Greenland. Hi, Hugh. We're at medical school together. We've been friends all our lives, since those days. And he's a gynecologist in Perth, and he's always going on about how lovely Australia is. And it's so many photos of blue skies every day. I go, just please leave me alone in my NHS grey skied Britain. I'll be okay.
And your wife travels down here, I think. Louise.
So my wife, she's quite. She's much more important than me. She is Louise Newson, menopause guru, the menopause doctor, and she was down here lecturing in November. In Australia, but we couldn't combine our visits, unfortunately.
I think they will see them back. They could move here for 6 months or a year more. We'd love to have you around a bit more.
Absolutely. So you have to introduce yourself as Louise's husband.
I do, and it's not unusual for me to go on the wards where I've worked for 18 years, and all of a sudden they say, oh my God, I don't believe it. You go, what? And say, you're Louise Newson's husband. Jesus, I just changed my name.
Fantastic. Thanks, Paul.
Fantastic. Great to see you.
Thank you for having me.
All right, so here I am with Anthony Tarr. Welcome back to Australia, Anthony. You've just come back after your fellowship. This is your first USANZ conference since you've returned.
Yeah, so I'm just, I haven't been back for a long time. I went in 2019 for my fellowship, and they were nice enough to give me a job. So I actually stayed on as a consultant for 3 years, but I've been back 3 months, so pretty fresh.
Fantastic. And what's it like being back? The last time you were here, you were a trainee.
Yeah, I mean, it's pretty exciting. It's nice to kind of see everyone.
Yeah.
Lots of people here I haven't seen literally for like 5 years.
Amazing, yeah.
Really good to catch up with everyone.
And tell me about your fellowship here. You were at UCL in London. What was that like? Was it a good experience for you? What are your main sort of takeaways from that?
Yeah, it was a fantastic fellowship.
Yeah.
UCL is it's a pretty high volume robotics center. They do like 800 to 900 prostates a year, 80 to 100 cystectomies.
Yeah.
So my fellowship was great. As a consultant, I was kind of employed to do all sort of pelvic oncology. So from my perspective, it was like an amazing experience.
Yeah.
But also living in London and enjoying everything that London and Europe had to offer. It was amazing.
Not too shabby for Anthony.
Yeah.
So tell me about robotic cystectomy, because that is now an area of interest for you and what you've really sort of spent your fellowship doing. Have you started doing them here? What are the advantages, do you think? And how will you change things for us in the next 5 years?
Yeah, I've only done just the one since I've got back. We were doing everything intracorporally. You probably know of the IROC study that got published, I think 2022. Yep. It's like probably the only positive randomized robotic trial in that exists in urology. And so the difference between that study and the previous cystectomy studies was that they did everything intracorporally. So I do think that it is the future for bladder cancer, and hopefully it's something, a skill that myself and others who do it can disseminate. But I think the major advantage is, in the elderly patients, the really comorbid, the really obese patients that maybe we couldn't do an open cystectomy on. I think there's an option for them now.
Absolutely. And, you're going to be talking in the robotic surgery workshop or a concurrent session in a couple of days, and you're going to specifically be talking about female cystectomy. Without giving too much away, what are maybe the top 3 points we should take away from that?
Yeah, I think we probably ought to be doing more organ sparing in females. You think, all the money, all the time we're investing in prostate cancer to save a little walnut-sized organ, whereas in females we're quite happy to rip out the whole pelvis for what is often like T0 disease in like a third of cases. So I think probably we should be doing it a bit more often. I'll talk a little bit about some of the data that we've got from UCLH, and then I'll show a video on how to do it. It's not something that's particularly difficult, but we ought to be doing it more often.
So that raises a good point, Anthony, because I've always wondered about the learning curve for robotic cystectomy. How do you address that issue with our trainees here, most of whom go through training without a lot of exposure to robotic surgery? Is a fellowship needed, or is there another way to train?
It's a really good question. I think at the moment, without there being robotic cystectomies or robots in the public, and without trainees having access to that, I think at the moment, you probably do need to do a fellowship to do cystectomy. I mean, I think taking out a bladder is not difficult, but the nuances are in things like organ sparing, nerve sparing, and especially in the reconstruction.
Absolutely. Well, Anthony, it sounds like you're going to do amazing things. We look forward to watching your career grow and develop. Congratulations again, and welcome back.
Thanks for chatting with me.
All right, Declan, we found him, the one person who uses ChatGPT more than you do. So we're here with Professor Axel Merseburger, Chief of Urology in Lübeck, Germany. Welcome, Axel.
Well, thanks Renu. Thanks, Declan. First time in Australia. Great honor being in this conference.
I can't believe it's your first time in Australia. It seems like you just seem part of the family at USANZ.
Well, thanks. And as you know, I messed it up last time with my visa, but now fortunately everything works out, and thanks for this great organization. Thanks to the committee, and thanks to you for having me here. Thank you.
Yeah, it's been great to have you. So you did do a great talk today, and the cheap ChatGPT comment is because very cleverly, and I think the audience really enjoyed it. He highlighted how you can use ChatGPT to explore a topic of new interest, and I did the same this time as well for my talk this morning. I used ChatGPT to create some images just as a way of a backdrop, and it's incredibly powerful. You did talk about how these large language models can be used probably by patients as well to get information. So can we have a word about your thoughts on using these AI tools in patient education? Or
yeah, I mean, Declan, you got the message correctly. I mean, it's not just the joke about the image and that everybody can create, even our kids, but it's about like the patients are confronting us with really up-to-date knowledge. And this is, I think, something we need to work with, and we need to stay up-to-date with how we treat our patients with advanced disease, like in this case, the talk on advanced prostate cancer.
Yeah, totally.
Definitely.
It's always really enlightening to see a urologist who deals with the whole spectrum of prostate cancer, and it's a rare breed, I think. How did you sort of get into that, going from being a urologist, managing prostate cancer surgically, to now managing advanced prostate cancer?
I mean, this is a question especially being asked by medical oncologists. How can you move the robot and then do the chemotherapy? And this is what we do in Germany. And there's always like the slight comment, one has to be wrong or not good, like either the chemotherapy or the robotic part. But I mean, at this great conference we are here now in Adelaide, I see a lot of the spectrum of urology where I'm not an expert in, like penile prothesis, like female urology, like incontinence, BPH, and all this. So we have to specialize. And in geo-oncology, it's for me prostate cancer and bladder cancer, where we run clinical trials, where we give treatment for advanced disease, and then it's the part of treatment surgery, like you have proven to the world, and you have proven to the world that it's possible to run trials. Lutectomy trial you've shown at EAU last year. So I think we can do both, and I think we should collaborate as we show on a daily basis with our colleagues in medical oncology, radiation oncology, and nuclear medicine. I think this is the secret, and pathology and the other specialties I've forgotten now. But I think it's very important to just speak, collaborate, and use our strengths where we are educated and trained.
And can we ask you about, because a lot of general urologists listen to this podcast as well, and it's a very exciting time in metastatic prostate cancer with these AR pathway inhibitors have come right forward, and you showed this data very convincingly, doublet therapies and so on. And now they're becoming reimbursed in many regions around the world. And here in Australia, only in the past 12 months, we have drugs like apalutamide, darolutamide, enzalutamide becoming reimbursed. So these are urology patients newly diagnosed with metastatic prostate cancer. So a question we still face here is, well, who should be looking after these patients? Do you think that the general urologist who's busy looking after his or her patients with stones and will have occasional prostate cancer patients, can they be equipped with the knowledge to select a drug and supervise the management of a patient with AR pathway inhibitors, or should it be sent to specialist urologists like yourself who are very interested in metastatic cancer, or medical oncologists?
Honestly, I would really motivate and encourage the colleagues here, especially in the areas where it's just the urologist treating the patient, and looking at such a large country here in Australia with such a clustered population in those big cities. I think it is very important that every urologist knows this field. And looking at back in the history, we had 2 Nobel Prizes on ADT, one awarded, it was a urologist that won. The last was Jack Shelley for LHRH antagonists. And so I think it's within the field historically, within the field of the urologist. So I think when you give ADT, you can give an androgen receptor antagonist. It's a piece of cake, I would say, and you just need to look at some side effects, but most of them are like within the same range what we can expect with classical ADT antagonist or agonist. And so a take-home message, I think we should motivate, we should go away from ADT monotherapy, we should at least give a doublet, and in some patients even triplet makes sense.
Absolutely, and I think you're right, Axel, because the situation has really changed. In the olden days, urologists used to look after patients from diagnosis to death, but that was when it was all ADT and maybe an orchidectomy for castration. But things have changed now, and as Fred Sard famously says, don't dabble in it.
Don't dabble.
Don't dabble. It was Fred's comment. So I think it is important, if you're interested in the management of prostate cancer, you have to know the data. And if you're not willing to be the one prescribing or looking after these patients, make sure you refer early.
Fully agree. Thank you, Renu.
Thank you, Axel. Enjoy the rest of your trip.
And we'll see you in Melbourne too. You're going to be coming. We'll be getting you on for an official podcast. It'll be fantastic.
Thanks a lot.
Thank you.
Thanks, Axel.
So I'm with Joe Cresswell, Dr. Joe Cresswell, friend and colleague from the UK and president of the British Association of Urological Surgeons. Welcome back to USANZ, Joe.
Thank you very much, Declan. Pleasure to be here.
Nice to be back. Escaped the UK winter, popped down to Adelaide.
Absolutely. Yeah, I really enjoyed Melbourne last year.
Yeah.
It's a tremendously friendly society.
Yeah.
Great to be back again. And despite the fact we're about 10,000 miles apart, I think of all the societies, probably BAUS and USANZ have got the closest affinity. I feel very much at home here. Particularly warm welcome, and a big affinity between Helen O'Connell and myself, of course, as 2 female presidents of these associations. So, love it here. And the weather goes a long way to making me smile as well.
It really does. And you're right, there's a lot of affinity, there's a lot of similarities. well, culturally, but there's a lot of similarities in urologic practice as well. And so
definitely.
this morning in the plenary, you delivered a fantastic talk about bladder cancer, which is your main clinical area of interest. And you talked about cystectomy. I thought it was very reflective of you when you thought about these decisions to do a cystectomy, it's the biggest operation we pretty much do as urologists. And you talked about how we can, I suppose, make this an experience for patients that we can improve. So things like, for example, pelvic organ sparing surgery and so on, minimally invasive surgery, and a sort of de-escalation approach as well. Do we really need to take out all the bladders that perhaps we have been taking out? So do you want to talk a little to us about those sorts of things in trying to get the balance right, because we don't want patients dying of bladder cancer. It's a terrible disease. But in making sure that cystectomy, when offered, is delivered in the best quality environment.
Well, I don't think my opinion's unique, first of all. I think these are topics that have been discussed in societies around the world. Radical cystectomy, really morbid condition, as an operation, lots of complications. In a patient population who will often have more than one other health condition. So these are fairly high-risk patients having big surgeries. And you have to think very carefully when you're making decisions, sharing that decision with a patient, whether it's going to be in their best interest to go for that type of surgery or not. And we need to also reflect on how we're progressing our work in this area. How are we staging our bladder cancers? How are we adopting multimodal therapies? Because a lot of people who die of bladder cancer are dying of systemic disease, and we're not very good yet at predicting who is going to be cured by a cystectomy and who really needs systemic therapy and maybe doesn't need a cystectomy at all. We also, I think, for too long have been doing the same operation over and over again, albeit we've adopted robotic surgery, we've had ERAS protocols, lots of things that we've been increasing our sophistication with. We've been taking out the same organs. We haven't considered pulling back. And I think that's partly due to the poor overall survival rates for muscle-invasive bladder cancer. It's hard to pull back when you don't think you're doing very well.
We're worried about the idea that if only we'd done a little bit more, perhaps this patient wouldn't have these.
Exactly. And I think the whole paradigm around lymph node dissection, if only we took out more lymph nodes, we'd identify more metastatic disease, we could cure more people. It's quite hard to pull back from those things without good evidence. If you look at oncology trials, often they escalate treatment, get to a point where they're getting good survival, and then they look at reducing doses, dose escalation. And I don't think we've been terribly good at that in surgery. And I think bladder cancer is one of those areas where perhaps we can pull back. I'm sure, in prostate cancer, there'll be a similar element over the next decade of how we adopt, where does radical prostatectomy fit into this array of so many different treatments. It's really exciting times. It's nothing to be depressed about. I don't think we should be saying, surgery is on its way out, this is it, heads drop. I think we should be embracing all these wonderful opportunities of getting into lots of different types of treatment and collaborating with colleagues to get the best outcome for our patients. Health-related quality of life for bladder cancer is probably the worst of all of the cancers, certainly is in the UK, so that we've got so much to do. It's an exciting area to be in because there is so much progress we can make.
And one of the things I think you spoke excitedly about today was you set the scene of the patient has had neoadjuvant chemotherapy and then we've done a cystectomy and there's no cancer left. And so we might cheer and go, well, this is great, your prognosis is great. You literally said it like that this morning. But the patient might say, I've been through this bloody huge operation. Look at me, I'm still recovering about this bag. So, and yet I think you pointed out that a more precision approach to try and figure out that beforehand and maybe say, well, maybe we can avoid a cystectomy for these patients. Do you feel that's an area that's improving?
I was very careful to say that this was horizon scanning. I don't think we're there yet because the big point here is we can't predict the patient who's going to have a PT naught, no cancer in their bladder. We can sometimes, but it's not accurate enough. So it's you're risking the patient's life, risking the potential they could have a curative operation if you don't do that. So we're not there yet, but if we can get better at our staging with imaging, using different types of imaging, and also all of the urinary biomarkers and the serum biomarkers, I think we can progress in this area and we can be more refined in who will benefit from a cystectomy. I'm not saying cystectomy is no longer an option. I'm just feeling that there's a big proportion of people who don't need that operation. They need something else. And When I started doing cystectomy, I used to be very robust with the patients. You have neoadjuvant chemotherapy, and then either you have chemoradiotherapy or you have your bladder out. You can't stop at chemotherapy. And patients were being quite logical. They were saying, well, why not?
Really?
My bladder looks okay on the scan. Why not? I'm starting, like many others, to reflect that it's not okay to take out 20% of bladders that have got no cancer in them. You can argue, of course, the counter-argument, I'm sure you're about to probably make it, that those patients are very high risk of developing de novo cancer in their bladder again and again.
Yes.
And that is an argument. However, we work with an elderly population, so whether they would have that recurrence and ultimately have to have their bladders out, from the very meagre data we have, only a proportion of them will subsequently have to have their bladders out. So I just think we need to take a good, long, hard look at it. You don't just keep doing the same thing over and over again, getting poor results in terms of cancer outcome and poor results in terms of health-related quality of life.
But and I think a theme that we certainly explore in prostate cancer is accepting a little bit of uncertainty. And I like to talk to patients about this because, of course, it's a shared decision making. So that decision to take out the bladder after maybe a really good-looking response to neoadjuvant treatment, and if the patient and clinician are accepting of some uncertainty, well, perhaps that's an okay thing. I think accepting some uncertainty in oncology is actually not a bad thing, especially if you're weighing up against a cystectomy and quality of life to say, look, there's this, there's that. So, that's a theme.
You make an excellent point, and I think we have a similar decision in bladder cancer when we're talking about high-risk non-muscle invasive disease that maybe hasn't responded to first-line treatment. I'm going to be talking on Tuesday about what we do in that circumstance, and it's when to pull that trigger to take the bladder out, and that has a degree of uncertainty about it. I think much of it is about really getting to know your patient, what's important to them, and really sharing with them what they're getting into. Because, of course, if they keep their bladder, they are getting into a very, very, very intensive program of surveillance, which, depending on your setting, might not suit you. I'm standing here in a very big country where, if you live thousands of miles away from your centre, an intense program of very high intensity surveillance, I don't think that would suit you very well. So you don't just say, look, do you want your bladder out or should we keep your bladder? I mean, that's a no-brainer. People say, well, I'll keep my bladder. But if you say to them, well, you're going to be coming back for a check of your bladder every 3 months, all of these CT scans, you're going to have all of these things done, I think you really have to be very honest and open about these things. So people can make, the patient needs to make the risk assessment for them with your support.
Finally, Joe, it's your second year as BAUS president now, so you've got another BAUS meeting to look forward to. Do you want to tell us a bit about it, or any highlights you're looking forward to? Where is it on, and when's it on this year?
So it's the 23rd to the 26th of June. It's going to be in Birmingham, which is right in the centre of the UK, easy to get to. It's going to be my last roll of the dice as president. I've got to say, being BAUS president has been a fantastic experience. I'm sure Helen feels the same about USANZ. I would really encourage anyone out there who wants to get involved in leadership of their organisations to do it. It's an amazing thing to do. Such a community, urology. Never ever look back. It's been wonderful. The BAUS meeting looks fantastic. Joe Phillip is our secretary. He's been doing a lot of work. We've got some big hitter celebrities, some sports people coming along who are going to be talking about their advocacy for urology. So that'll be really interesting. We've got lots of excellent scientific sessions with some really good UK trainees presenting their work. And we've got some sessions around widening participation and EDI that are important to us as well. I know that, for example, RACS has been through this already, but big report out from the Royal College of Surgeons of England around sexual misconduct in surgery last year and in the wider health service. We've got a lot of work to do with bystander education and all these themes, and we're bringing these into the meeting, and they're going to be in the mainstream plenaries, because it's got to be everyone taking this on board and helping us move forward. So it looks really exciting. I'll be looking forward to inviting Helen O'Connell, my counterpart, back to Birmingham. It'll be my pleasure to be her host and return the fantastic hospitality I've had here.
Great to have you down again. Thanks, Jim.
Thank you very much, Dan.
All right, so we've just finished a plenary session, had a very lively debate in it. Gleason 4, surveillance no more. I think you had your work cut out for you. Nathan argued for the affirmative, and Alan McNeill argued for the negative. But great result, Nathan. It was a tough debate.
Yeah, well, as I alluded to in the in the preamble, I felt it was a bit of a straw man situation where I'd really been given an impossible task that was always going to be shot down. But the truth is, Declan and myself and Naranjan did write a paper that came out in 2016, so probably written in 2015, saying Gleason 4 surveillance no more. And as I pointed out, it probably should have had a question mark at the end of it, because back in 2016, MRI wasn't freely available, transperineal biopsy was just coming on board, PSMA PET CT certainly wasn't being thought of in active surveillance patients, and it was really a different era.
Yeah.
And I think at that time there was uncertainty. Long-term data from the PROTECT trial wasn't available, long-term data from Laurie Klotz's series wasn't available, and so on. And there was some angst about should we be allowing men with Gleason 3+4 to come along. And the other thing that changed is, back then we weren't as rigid in dividing men into favourable intermediate risk versus unfavourable. So I think on the grounds, we know the EAU guidelines, of course, do say we can put in men with favourable risk Gleason 3+4 on surveillance. But indeed, the times have just changed. And really the challenge for us now is how far can we push those boundaries? What tools can we use? PSMA, PET, MRI. Do we need to do repeat biopsies? Yes or no? Targeted biopsies only? Genetics testing and so on. So I think the debate really is not about whether we can have men on active surveillance with pattern 4. It's how much pattern 4 will we tolerate. Exactly. And then to Alan's point, are we just, by putting more men on surveillance potentially, are we just moving the gears of a side effect down the road? In other words, we might be able to have men live for longer or the same amount of time, but the ones who haven't had radical treatment, are they going to be more prone to having diseases related to hormonal manipulation, metastatic disease and so on? And that's a really, really interesting concept when you start to bring into discussions on active surveillance, metastases and so on, when you're talking about men with the earliest form of cancer they can have.
Absolutely.
Yeah, I think in the end it wasn't really a debate about whether Gleason pattern 4 can undergo surveillance. It was more a discussion about how do we pick out the men who are likely to die of their disease if we don't intervene. And the value of the PROTECT study for me in my practice is the quality of life data that has come out of it, because no surprise really, the percentage of men dying of their cancer is very low because by its nature the PROTECT study detected early disease, Gleason pattern 3+3 or 3+4 in the main. But the quality of life impact was this similar whether a man had monitoring, radiotherapy or surgery. The side effects associated with each treatment were different. So I think the discussion is really about predicting who's going to die. If you don't treat them, they need treated. Those who have got 15 to 20 years to run, whatever you do, then need to be counselled about the pathway and the side effects, the quality of life impact that they may experience along that 15 to 20 years, and then choose their treatment path.
Yeah. I mean, it's when you look at the topic and you're arguing that no, surveillance is not, out of the picture for Gleason grade group 2 disease. We know there's a proportion of patients that we can safely watch for a good significant period of time. But there are so many nuances to it, isn't it? Because, it's a sort of disease entity that makes people very nervous. And I think counselling patients is really key here. How do you approach counselling patients when it comes to recommending active surveillance for grade group 2 disease?
Well, I've worked with a charity called Prostate Scotland for 17 years, and we've developed a website, we've developed booklets. We encourage men to record when they come to see us so that they recall what was said much better. And at the end of the day, there are men and families who are going to say, I don't care whether I've got 15, 20 years, I want this treated because the small chance that it might progress is enough to make me want treatment. And I think you have to recognise that. The way I deal with it is to say to them, look, go away, come back in 6 months with 2 more PSA tests. You will either remain convinced you want to have treatment, in which case fine, because it's not an emotional response, it's been thought through, or you will have got your head around the fact you've got this early prostate cancer and you've seen 2 PSAs stay the same, and you may be more comfortable with the idea of surveillance. So it's not a one episode for these guys.
Yeah, it's definitely a journey.
I think it's like I said in the talk. I always like traffic lights. It's really easy. People understand green, amber, and red, and I think you can be really subtle about that once you have the biopsy result. But if you can set that up before the biopsy, the patients are not scared of that. You say, look, it's all called cancer, but the stuff at the bottom, we just watch. It really shouldn't. I tell patients, I said, we go to debates at the AUA or American meetings or European meetings, Australian meetings, where we're not even sure if it's really cancer. But I think what's important with the traffic lights is I can say to patients, how you're going through a traffic light and it turns amber just at the end and you were safe, you were fine, you were never going to get a red light camera fine. That's the 3+4. However, if you're entering the intersection when it's already amber, it's going to turn red at some point. That's more like the 4+3. And I draw that in a diagram and the patients can actually think about that and go, it's an amber light, but it's really not that bad. I'm not going to go through the red light. And I think you've got to use these analogies, whatever works for you. And that's a really simple decision aid. I know there are more complex ones. You look at the Navigate trial, the work done there were fantastic decision aids that were made for patients. So I think as urologists, we probably should use better decision aids, but if you can get away with using really simple things and patients respond to that, that may be all you need. They just want that reassurance from the clinician.
And it's important for patients because not only do they want that reassurance, then they need to explain it to their family.
Correct.
And that opens a lot of issues if you're not able to communicate the basis for that decision to the rest of your family and your loved ones.
That's why. So our centre took part in a trial called the Navigator project 20 years ago. And basically it showed if the patient had a transcript and an audio recording of their consults, they tended to listen to those or discuss them with the families up to 3 times.
Wow.
But the result was that the decision regret was very low in those men. And the confidence that they'd made the right decision about the treatment was much higher.
Wow.
So it's not one size fits all. Some men don't want to read anything, they just make a decision or tell me what to do, doc. Yeah. Others need all the information. They need the prostate cancer support groups and the buddies and to help them. But reinforcing the fact that this disease has a 15 to 20 year natural history and there is no need for an immediate knee-jerk response is the key thing.
Yeah, absolutely.
And the fear that it's going to change in 6 months or a year, for most men, it's not going to.
Yeah. Well, thank you to both of you for providing such an interesting and lively debate. It's amazing how much there still is to talk about when it comes to Grade Group 2 disease. Alan, you're one of our favourite international guests. Welcome back to Australia. I should have said this right at the start. Are you enjoying your time here?
Yeah, we've had another great trip. It's always a pleasure to visit USANZ. The friendship, the welcome, the hospitality.
Excellent.
It's wonderful.
Well, it's been a pleasure having you. Keep enjoying the meeting. And Nathan, enjoy the meeting. We'll see you back in Melbourne.
Indeed. All right.
All right, so I'm here with the main man, Michael Choong, convener of USANZ 2024. Michael, congratulations.
Thank you, Renu. Look, we're getting there is where I'd be at the moment.
You look pretty good for someone who's been working very hard for the last year.
Well, that's because you didn't see me beforehand with and see how many grey hairs I had like a week ago.
What's it been like seeing the meeting come to fruition?
Oh, look, it's been a fantastic experience. I mean, I've been saying to people it's a bit like your wedding, In fact, it's probably bigger than your wedding.
Yeah.
For my wedding, you just make sure you got a clean suit, shaven, and you got your hair cut. But with the meeting, there's a lot more worries than that. I've been thrilled with the response of how positive everyone's been. It's been a very positive vibe at the meeting, hasn't it? And that everyone's generally very happy. It's been wonderful to see old friends. Some of them I haven't seen for 20 years.
Absolutely.
I've just been thrilled. The feedback from the sessions has been great. I think everyone would agree that the sessions have been really good.
Amazing. And you've had a fantastic team working with you. Scientific convener Dixon, Woon, and the whole team behind this. It's it's teamwork really.
Oh, absolutely.
And that's very obvious in the way that you've pulled this off.
Yeah, look, you can't. Many of those I think who have been in the shoes before know how Dixon feels. He's done an outstanding job, and in the end, the marketability of the meeting is about the scientific content in the end. I mean, there's all those other bits on the positives on the side, but in the end, it's down to the academic program. And my hat comes off to Dixon. He's done a wonderful job.
Yeah, and I think there's been some unique things about this meeting. The section on transgender care and the multidisciplinary meeting and the plenary session we had today. I mean, it was very moving. Very unique thing about this meeting.
Yeah. I must admit, I didn't see a lot of that coming. How this meeting would strike such a personal note with so many members of our audiences and the delegates. I saw tears yesterday in that Harry Harris oration. I mean, I felt the heebie-jeebies before. I think we all kind of can see how we are all immigrants in some one way or another, and I think that struck a chord with most people, as with the diversity session.
Absolutely. Yeah. And when you're planning a meeting like this, how do you strike that balance between sticking to tradition and what's been done in the past, but also having a point of difference?
Yeah, look, you've always got to stick to the script somewhat, don't you? Yeah. And as I said, that is in the end what has been what you've got to deliver. But no, I think you've got to. I think Declan and Janelle set a very good example last year, in that this meeting is. There are messages from this meeting that aren't academic. Let's put it that way, and you've got to pass those on. Particularly, you look at Jonathan Masters' talk, Paul Anderson's talk. We are very lucky people in this country.
Definitely. And speaking of those guests, I mean, you've lined up a stellar cast of international speakers, and I think that in itself must have been quite a feat.
Well, again, credit to Dixon.
Yeah,
Dixon's gone out and met everyone, and asked them to invite them along to our meeting. I can't say enough good things about the international faculty. They're just wonderful, normal people. You're talking to them about quite often not about urology.
Yeah, and will you get a chance to relax and just enjoy some of the content, the social activities in the next few days?
Hopefully I'll get to enjoy some of the content, the social activities. The answer is yes, absolutely. And again, it's a humbling experience, but something that I guess you take away, and maybe in a week's time I'll look back at it and go, well, that was pretty cool.
Yeah, that's right. In retrospect, when you're going through it, you may not understand quite the power of what's happening, but when you look back on it, I'm sure the impact of it will hit you. Well, congratulations, Michael, for putting on such a wonderful meeting, and we look forward to the next few days.
Yeah. Thanks, Renu. I'm glad you're having a great time.
So here I am with the man of the hour, Dr. Dixon Woon, scientific convener of this year's USANZ. Dixon, congratulations. You must feel pretty proud.
Oh, thanks for the introduction. I'm relieved, I guess everyone landed now.
Yeah.
So no one is on the plane.
That's a stress for sure, yeah. I mean, you've got a stellar lineup of international guests. Was it hard to source them, hard to get them to commit, or was it easy? Did people love an invitation to Australia?
I think we are really lucky. We have really sort of keen international speakers, and USANZ has been well known for their generosity and hospitality, so they all basically take up the invitation straight away.
And, it's only day one. We've had workshops today, but you've put together some amazing sessions, particularly interested in the first transgender multidisciplinary meeting we've ever had in USANZ. What was that like? Was it?
Yeah, I think that's actually one of the things I'm most proud of. It's a very diverse sort of content, and the first transgender workshop have well received. We have about 60 people turn up.
Yeah.
And was a very emotional, very impactful sort of session.
Yeah, absolutely.
A lot of the audience are actually crying during the session. So I hope that will be the beginning of an ongoing sort of collaboration. and to help the transgender population.
Absolutely, and I really hope that continues, Dixon. And what I love is that you've put your own little spin to this meeting, your trademark, and that's really impressive. And hopefully, it's a legacy that continues.
Yeah, I think I learned from my own personal journey. I don't know much about the transgender health, so I don't expect other healthcare worker knows, anything more. So
Absolutely.
It's a good chance to advocate for people in that community.
And what are some of the other highlights we should be looking forward to over the next couple of days?
Yeah, so a couple of them. One is the debate about open versus robotic surgery. The great Declan Murphy versus Rob Nam. And then we'll have, on Monday, a whole session on prostate cancer, including prostate cancer in the New Zealand Maori people to the Fijian community. And also, on the last day, which will be the key highlight, the future of urology.
Yeah.
We talk about all the innovation and also what sort of new invention there's along the pipeline.
Yeah, and what I've also noticed here, Dixon, is there's a real presence from EAU, from the Korean Urology Association. I mean, you've really kept those relationships going.
Yeah. I think that's the strength of USANZ. We are, welcome, different society from different part of the world. We always show them that we're keen to have them on board. I think the exchange of knowledge is the key to keep, USANZ so vibrant. And, anywhere else, better than Australia to visit.
Absolutely. Well, Dixon Woon, we are so proud of you. Congratulations again. We hope that you get a little bit of downtime over the next couple of days and enjoy the conference yourself.
And thank you for your help with all the talks that you put into. Really appreciate it.
You put me to work.
I'm lucky I have good people around me.
Thanks, Dixon.
Thank you.
Look who I ran into, Shane LaBianca. Hey, Shane.
Hi, how are you?
Good, how are you?
I'm good.
Enjoying your time in Adelaide so far?
Yeah, lovely. So far it's been great. A fantastic first day, which is really good.
Fantastic. And now you're convener next year.
Yeah. So I've got the gig for Perth.
Yep.
So this has been 4 years in the planning because 2020 didn't quite go off because of COVID. So I get another go at it.
Fantastic. So what can we look forward to?
Well,
we barely started 2024, but what can we look forward to for USANZ 25?
It's only a hiccup. So this is the real thing now. And look, it's Perth. It's sunshine and good weather and beaches and everything else to have a really relaxing and enjoyable, 4-day, 5-day, 7-day break.
Absolutely. And it's only 3 hours to Singapore. So what can we expect in terms of international guests? So where are they? Is that going to influence your selection?
I think the good thing about Perth is that it's sort of, depending on your perspective, it's central to a different area geographically. And I think, we're focusing on Asia and Europe. And we've already got, 3 or 4 speakers sort of locked in, which is great. So Trent's doing a great job already. I just have to keep him in line and just keep pushing him along so that he gets the job done. But it's looking great. So I think, ideally, if we can get good numbers to come to Perth and enjoy what we've got to offer, I think it'll be a great meeting.
Well, congratulations, Shane, and we're really looking forward to a fantastic meeting in Perth next year.
No worries, no problem at all. See you then.
I really enjoyed that meeting.
You do leave these meetings, especially the USANZ meeting, feeling quite enlightened and happy to have caught up with friends and colleagues from around the world.
As usual, that's still the best bit, is seeing people, isn't it?
Yeah.
People we haven't seen, because sometimes it's still a bit post-COVID, isn't it? Some Australian, New Zealand colleagues we haven't seen, international colleagues we haven't seen, so catching up with people is number one highlight for me.
Yeah, and we saw them on and off, didn't we? There were a few trips to the wineries, I think, for a lot of people, and rightly so. You are in Adelaide. It's
and the
South
beaches,
Australia.
the Europeans just, they needed to get some summer, so they were all down on the beaches.
And luckily they all had our GUcast merch with them.
That's right. And you can see in these pictures here some of the guilty parties who snuck out between plenary sessions. Yes, Axel and Faisal, that's you.
That's you guys. It was a great meeting, and I think there were a few things that made it very unique.
What did you like?
All the sessions on diversity were fantastic.
Yeah.
I really loved the transgender multidisciplinary meeting.
Amazing.
And the plenary session on that. That was really very emotional and moving, and I really admired the courage of all the speakers.
And that was one of the themes that was deliberately built in by Dixon and the scientific committee. And the other theme they had in was about outreach urology, as they kind of roughly called it, and providing urology services in low and middle income income countries. So we had amazing tales from the Pacific Islands, experience of managing urologic cancers and other conditions. And we had Paul Anderson talking about his outreach work in Africa. Yeah, so that was, and it's always you get very reflective when you see some of the work these people do and looking after these ever so gracious patients in terrible circumstances. So
absolutely
important part of the meeting.
Yeah, and Dixon and Michael really put on a great show, and I think it's many memorable moments.
Well done. That's all we have time for. We just want to thank our main partner on the podcast. Bayer China have come in this year to help us put on these conference highlights packages. So thanks to all at Bayer China for supporting our GUcast conference highlights this year. We'll be back with more highlights soon. What's the next meeting?
Oh gosh, EAU is coming up soon.
Yeah, EAU is next month.
And of course, next year we'll be back again with USANZ 2025. It'll be in Perth in February, and it'll be convened by Shane Bianca, and scientific convener will be Trent Barrett.
That's great, and it was good to hear from them during the podcast as well. They've obviously already got a lot of exciting things in place, but if you're listening to this from somewhere else other than Australia and New Zealand, come on down here. This is a great meeting to come and visit. It's always a nice time of the year coming to Australia in February, so maybe we'll see some of you in Perth next year.
See you soon.
Bye.